I'm Esther Kim. I'm a neurosurgeon at Loma Linda University Health in Southern California. And thank you for joining us today. As you know, these are unprecedented times and we've all had to change our practice to provide the best care for our patients. And I'd like to thank Dr. Yu and all the program chairs for this invitation to speak. Okay. So I have no conflicts of interest to disclose, and I'll just be kind of making a few comments and an overview about the effect of COVID-19 on academic practice, specifically a little bit about policy, fiscal impact, practice impact, specifically at our institution at Loma Linda, and the training impact, especially at an academic practice. That's kind of our MO, is training residents and future clinicians. So this is just a short little condensed timeline. In December, as we all know, China reported the cluster of pneumonia in Wuhan, and then Chinese officials confirmed of the novel coronavirus. The first confirmed case in the United States was in the state of Washington in Snohomish County in January. From a policy perspective, the American College of Surgeons recommended health systems should, quote unquote, thoughtfully review all scheduled elective procedures in mid-March. And then soon after, the US Surgeon General recommended halting elective procedures. In the state of California, the governor issued stay-at-home orders soon after that. In about mid-April, the American College of Surgeons recommended reviewing 10 distinct issues prior to any elective surgeries to be safely reinstated. So from a fiscal point of view, the American Hospital Association has estimated that hospitals will lose approximately $202.6 billion due to COVID-19. A lot of this has to do with the changes in hospitalization rates, specifically reduction in things that we routinely see, like heart attacks, strokes, and even trauma. There's been during about April, there was an 80% reduction of motor vehicle accidents coming into the hospital. And then with the cancellation of surgeries, as mentioned previously, that has been the bulk of the loss of revenue for our hospitals. And then some additional costs, such as purchasing PPE, along with additional staff support. So on a personal note, many of us have been fiscally impacted, as noted on our survey. 78% of people reported that they've been impacted. 266 hospitals at the minimum have furloughed workers in response to COVID-19. These are just a couple of different academic programs that have had to furlough or cut pay, and some of the estimated losses. Mayo estimating about a $3 billion loss, Ohio State, probably over 300 million revenue loss, and Mass Gen, 1.6 billion in just the second quarter alone. So from a practice standpoint, 96% of respondents reported that their practice has changed. And the luxury of being in an academic setting is that we have a diverse pool of people with multiple different specialties that are able to come together and develop local hospital policy changes. And so, some of the changes, as Yujung had even mentioned, is, changes in terms of having, have most of our staff work remotely at home when possible. And, and then there were staff that were also furloughed with forced vacation time or forced CME time to be taken, along with pay cuts. There was a quick adoption of telehealth services at our institution. We used a combination of Epic MyChart, Zoom, and Jabber, and this was both for outpatient services and some inpatient consults. As I mentioned, there was a reduction in stoppage of elective procedures, and we began starting that pretty soon after. Now, on the next slide, it'll show kind of our timeline at Loma Linda. And then, as the pandemic occurred, as the increase in infections in the United States, there were rapid fire changes to practice workflows and policies. This is just a small little example of kind of the communications, and this is just the video communications. This isn't the emails that were being sent, multiple emails during the day in terms of the changes that we were having to implement because of COVID-19. And I'll go through a little bit of the workflows on the next slide. These are just, we had to use an online portal just to disseminate the information because there were so many changes going on in a short amount of time. So this is just a short little overview of the response at Loma Linda University Health. When this pandemic first, when we first started responding to this pandemic, one of the first things that we did was we created a central command center. And that's where essentially all the information was being flowed through the hospital. Their initial stages were creating an 8-phase surge plan to essentially for the ICUs, the acute care units, and the ORs, depending upon the utilization of the hospital. On March 17th, we had our first COVID positive patient. And at that time, we changed our visitor policy where no visitors were allowed. And all elective procedures were stopped. Soon after, the California statewide shutdown was implemented. On March 23rd, we had our first COVID ICU patient. And around that time, we started implementing a universal screening questionnaire for anyone that entered the hospital, including a symptom questionnaire and temperature checks. And all personnel on campus were provided a surgical mask as well. In about early April, we were able to develop our in-house testing with diasorin testing. We obtained the point of care testing by Abbott. And after reviewing kind of all the ACS recommendations in regards to being able to reinstitute planned procedures is kind of how we call it, rather than elective surgeries, we started to start planned surgeries in early May. And then in June, recently, we were able to revise some of our visitor policies and allow visitors with a negative questionnaire, obviously, or negative screen. And then we revised some of our surge capacity as well. So one of the responses had requested looking at protocols in regards to how testing is done. And this was this is the most recent protocol that's been has been made. And this has gone through 100 different iterations, I'm going to tell you. And so it's been, that's why the online portal has been important for us to just be able to disseminate information. But there are different arms depending upon the timing of surgery, the response to the COVID-19 questionnaire. And so I'll go through this just a little bit. But essentially for emergency procedures and a negative screen, we're using the point of care testing. And if it's not a high aerosolized and generating procedure, then we'll typically use a standard room. Otherwise, we would have to use our COVID designated OR with the negative pressure room. If surgery is urgent, then we will sometimes use a diasorin test and then proceed to the appropriate room. And for planned surgeries, if there's a positive questionnaire or unable to be screened, there'll be a delay in the procedure. If negative, we'll typically do a outpatient test, either a Mayo, LabCorp, or Quest, 2 to 4 days before the planned surgery. And the patient is instructed to self-isolate prior to the procedure. If it's a high aerosol generating procedure, the patient is supposed to have a point of care test the morning of surgery. So from a training standpoint, as Dr. Rue mentioned, Zoom has become our major platform. In California, gatherings of more than 10 people were prohibited, and all in-person academic meetings were canceled, which included grand rounds, didactics, multidisciplinary meetings like our tumor boards, our journal clubs, and conferences. Attendings were also prohibited from traveling outside the institution, and just recently that has been lifted at Loma Linda. And 60%, 68% of our survey respondents have adopted a virtual platform. And as Dr. Ru mentioned, 79% of respondents have believed it's increased participation in educational activities, which is what we've also seen at Loma Linda. It's surprising. I think over 50% believe that the platform improved resident education, while 37% didn't believe that it impaired resident education. I think it's a mix. I think people do absolutely miss the in-person interaction. So as a part of that at Loma Linda, what we've done is we'll allow the residents and the speaker for that particular conference or the didactic to meet along. So it's a hybrid with an in-person and a Zoom meeting for the rest of the faculty and any other participants. Just so people know that ACGME in the United States does have an emergency response plan. So there's 3 stages in regards to response to a pandemic. Stage 1, business as usual. Stage 2, changing or suspending educational activities. And stage 3, where almost the majority of educational activities are suspended. I think for the most part, people are in stage 1 or potentially stage 2 with some more virtual meetings, obviously, and then reducing in-person meetings. Oops, I'm sorry. So I know this was a little bit of a whirlwind of an overview, but I'm hopeful that you were able to gain some insight and some information. Thank you for your time, and please be safe.